All right, thank you very much. I'm grateful to Amitabh and his team and PCSI for this invitation to the meeting here after 3 years of virtual meetings. So it's good to catch up with old friends and have a lot of these important discussions. The topic of sinus venosus defects, you've seen a very good example of a complex sinus venosus defect, which the team quite rightly decided not to proceed and refer for surgery. And that is an important point. And I think later in the program or tomorrow, we've got talks on this as well. But it's important also to address some of the hardware things. And these are my disclosures. I've taken this picture from Shiva Kumar's paper, which shows the challenges really in relation to sinus venosus defects. One of the challenges is the SVC diameter. It is distensible, and so the diameters that we get measurements from CT or MRI scans may not be entirely representative. SVC is non-stenotic, so it's important to do balloons assessment or interrogation. The defect, or if we're going to put a covered stent, has to be funnel shaped. For example, the SVC diameter varies from 10 to 30 millimeters, but at the SVC-RA junction, it may be even more than that, so somewhere between 20 and 40 millimeters. The pulmonary veins, as far as the anomalous drainage is concerned, pulmonary veins have to be redirected to the left atrium without obstruction. And what we've found is that the anatomy is not always clear because there is this high additional right upper pulmonary vein, which is quite remote from the defect, which will be difficult to redirect by catheter techniques. So CT, MRI scans, all these are important for us in terms of assessment. We have a reasonably good idea from those, and then 3D reconstruction can show you even more so where the right upper pulmonary veins drain and what the possibility is of redirecting them. And as I mentioned just briefly a little while ago, virtual reality, this is software from Elucis that we play around with and use for decision making. So here you can see how you can cut into the heart, you can cut into different views, look into SVC-RA junction, look into the defect itself, sinus venosus defect, and the pulmonary vein. So here you see the pulmonary veins, here's the SVC, and we can gradually cut in and convince ourselves about the passage of the pulmonary veins and redirection towards the left atrium. And then we can do other things like virtual reality, putting in a virtual stent, and then cut down various segments to show whether the pulmonary vein can get into the left atrium without any obstruction. So this is quite a useful way of evaluating using virtual reality. And you can see here, bottom right, the stent in the SVC as well. When it comes to catheter procedure, and stent selection is important and how we position it. In practical terms, we either need one stent if you get the right length, otherwise 2 stents will be required. And the combination of the 2 stents may be either 2 covered stents or 1 bare and 1 covered, the bare being at the top end and the covered being at the lower. Balloon interrogation helps in deciding that. The stent positioning at the upper level, at the highest, it needs to be at the nominate vein level or azygous vein level, but generally it tends to be below that. And ideally, the other guideline is that the upper end of the stent needs to be about 2 centimeters at least above the entry point of the right upper pulmonary vein. The lower level needs to be overlapping with the atrial septum by at least 2 centimeters at the start, because during the procedure we flare the stent, which results in shortening of the stent. And so if you don't have that 2 centimeter overlap with the septum, then there is a risk that the stent will shorten too much and leave a residual shunt. The diameter needs to be about 2 to 4 millimeters larger at the top end, larger than the compliant or non-compliant balloon. But at the lower end, it's a real tough assessment by transesophageal echo, because what you're trying to do is oppose the stent to the septum without tearing the covering or without migration of the stent. And I'll come back to that. The catheters and wires are straightforward, really. It's the regular 0.3 5-inch wires, and that can be Terumo or normal Teflon wires. Amplatz exchange length 0.3 5-inch wires. The sheaths, we generally go for 3 accesses, 2 femoral veins and an internal jugular vein. And for the internal jugular and the left femoral, between 5 and 8 French short sheaths are fine. But for the main one, through which you're going to implant a covered stent in the femoral vein, the larger sheaths, such as the Mullins, check flow performer, dry seal, or centrant sheaths up to 20 French are used. Catheters, simple really, main MPA catheter, multipurpose, Cobra catheter, JR4 catheter. Those are really just to maneuver into the right upper pulmonary vein. Snares, in order to establish a veno-venous guide wire circuit, gooseneck or multi-snares, and then transeptal needle and sheaths for transeptal puncture. As far as balloons are concerned, we generally start with ASD sizing balloons, such as the Amplatz ASD sizing balloon, the 34 millimeter, or the PTSX from NewMed, 40 millimeter diameter, for the interrogation of the SVC. And then we, depending on how much bulging there is of the balloon, we sometimes use non-compliant balloons, and that's again a variety, such as Altosa or ZMed, of up to 30 millimeter diameter and preferably 6 to 8 centimeter long balloons. Atlas balloons of different diameters, we have those available for pulmonary vein protection if there is a need, and Coda balloon for flaring the bottom end of the stent. Here's a Coda balloon from Cook. We use that for flaring at the bottom end. These can go up to a diameter of 32. They come in 2 different sizes, 32 millimeter and 40 millimeter, and you can get them to that diameter by the volumes, not by any pressure measurements, but volumes, 34 and 40 mils. These are high profile or big profile and require 14 French introducer sheaths. And then bib balloon technology. This is a balloon in balloon from NewMed, and that helps with the controlled delivery of the stents that we're putting in. The inner balloon is usually half the diameter of the outer balloon and 1 centimeter shorter than the outer balloon. And so it's important to remember those numbers. There are other alternatives available, such as from AndraMed. They have the Andra balloon, which is a single balloon going from 10 to 32 millimeter diameter. It's a non-compliant one. The lengths are 20 to 60 millimeters. And then the Andra 2 balloon, which is similar to a bib balloon technology, which is from 20 to 32 millimeter diameter and 40 to 60 millimeter lengths. And again, require 14 French introducer sheath. The other alternative is Andratec balloon, balloons made by Andratec, such as the Altosa XL and Altosa XL Gemini. These are either single balloon, non-compliant, or bib balloon technology. And again, their diameters go up to 30 millimeters and length up to 60 millimeters. So what are the requirements for the procedure? Well, the stent should not move in the SVC after implanting or anchoring. It should not compress the right upper pulmonary vein drainage. It should be long enough to close the sinus venosus defect. And really, as shown with the previous case, you should identify unsuitable patients, such as those with significant additional right upper pulmonary veins, which are likely to be either blocked or compressed completely. The choice of stents, that's important. We've used predominantly covered Cheetham Platinum stents from NewMed, but other operators, Shiva Kumar and others, have used Andra stent XXL from AndraMed, Some have, from Paris, Sebastian Haskowit has used the Optimus CVS stent from Androtech as well. And there have been a couple of cases with stent grafts as well, and I won't go into that. Of the stents, Andra Stent XXL covered stent from the Andromed company. It's a cobalt chromium stent. The problem is the length really is 13 to 57 millimeters long. It can be dilated up to 32 millimeters diameter and has a lower profile. But it's really the larger end which may cause a problem in terms of length, because the 57 millimeter long stent will shorten inevitably at the larger diameters, and therefore there will inevitably be a need for additional anchoring stents. The Optimus CVS from Androtech, fairly similar, cobalt chromium with hybrid cell design. There's closed cell combined with open cells seen here. PTFE covering, again, it's up to 57 millimeters long and can be dilated up to 32 millimeters diameter. The B graft, Bentley B graft, is another one, cobalt chromium, EPTFE covering, and slightly longer, it's up to 59 millimeter length, but above 18 millimeter diameter, they're available up to 48 millimeter length, and they can be inflated up to 30 millimeters as well. But the problem is the length. And again, if you have these shorter stents, then you're going to have to put in a second or even more than 2 additional stents. The predominant one that we've used exclusively in our unit and many of the other centers is the covered Cheetham Platinum or covered CP stent. The 8-zig is the one that is widely available, but the 10-zig is the one that we have custom made at the moment. And this is these are pictures of a 10-zig, 8 centimeter long covered CP stent. They're made from platinum iridium 0.13-inch, arranged in a zig pattern. So there are 10 zigs around the circumference. They're laser welded at each end, each joint, and then overbrazed with 24-karat gold. The covering is EPTFE, and it's glued. It's not sutured in, it's glued at each end, here and here. That depends on the diameters, but it's glued at either 3 points or 4 points in order to stop the stent covering from slipping off the stent. The 10-zig ones can be dilated up to between 26 and 30 millimeters, although we've expanded them up to 34 millimeters. The 10-zig custom-made one is available from 5 to 11 centimeter length. So this, if you can get the longer stents, are going to make the procedure that much easier. These 5 and 6 centimeter long ones are available anyway because they are CE marked. But if you use a longer covered stent, then you won't need another anchoring bare or covered stent, but the right upper pulmonary vein anatomy will really help you in deciding the length. The covered CP stent, as I mentioned, 8-zig can be dilated up to 24 millimeters. It's the 10-zig really that can be dilated more, 26, 28, 30 millimeter diameters. The length, again, up to 11 centimeter long. The diameters are 30, but they can be expanded up to 34 millimeters, usually at the bottom end, and the right upper pulmonary vein anatomy helps. Here's some of our experimental work initially before we embarked on the sinus venosus defect. We guessed that we would be dilating up to 34 millimeters, and SVC would obviously be smaller. So here's a 8 centimeter CP stent, covered CP stent that's dilated to 18 millimeters at the top end and 34 millimeters at the bottom, and it configures quite nicely. But you can see a little bit of shortening, and as you increase the diameter to 22 millimeters, 26 millimeters, and 30 millimeter diameter, you can see how much shortening occurs. So the 8 centimeter one's gone down to 56 millimeters, which is quite a lot, and that then determines what will happen to the procedure. We do sometimes 3D RA, rotational angiogram with the balloon inflated, and that tells us about the right upper pulmonary venous drainage, whether it's blocked or not, whether it's compressed or not. We've used transseptal puncture to get across. We use transesophageal echo guidance throughout the procedure very carefully to show that the defect, firstly, the anatomy, and secondly, what happens to the right upper pulmonary vein when the balloon is inflated. But very importantly, here is a very good example of the SVC stent overlapping the septum. But if you push a little bit too much, you'll see here, it's really precarious. It's still in place, but any more dilatation or flaring would result in the stent passing over to the across the septum, and so it would not be a good idea. Overlapping of stents, Shiva Kumar has given a very good example of two overlapping stents. It's important to overlap the inner stent inside the outer, longer covered stent. The inner one can be the bare one, and this is going to be at the internal jugular end, and this is going to be across the defect. So these are two Andra XXL stents overlapping on an 8-centimeter balloon, and that is an important part of the covering. You can mount one covered and one bare, or you can mount two covered stents depending on the lengths that you've got. Coda balloon, I've mentioned, very important. You can either flare the bottom end of the stent with coda balloon or a larger non-compliant balloon at the bottom end. But again, that's important. I'll very quickly flick through the techniques that we've mentioned. We do transseptal puncture. Here's some pulmonary vein and SVC angiograms. In AP and lateral projection, which are usually enough. With the balloon inflated, you really want to demonstrate that the right upper pulmonary vein is uncompressed and drains solely into the left atrium. This is a non-compliant balloon in position. And then once we're happy with going ahead, here's a covered stent, which is mounted on a bib balloon, which is then gradually inflated. The outer balloon is inflated, and then you see some flaring at the bottom and compression at the top end. And depending on what the angiography shows, here's the right pulmonary vein angio in the AP and lateral projection showing no residual shunt whatsoever. However, if you flare the bottom end, as you can see in this example, then it is possible to finish up with not enough anchoring of the stent at the SVC end, and the stent migrates downwards. So you then have to rescue the situation with pushing the stent up with a sheath and then putting a second stent to anchor the first one. Even the first stent, when you're inflating it, it can migrate downwards if you haven't got really good control. And so here we use the larger sheath at the bottom end to push the stent up. And whilst maintaining that position, we can then put in an anchoring stent from the internal jugular vein approach. And once the top end of the stent is anchored with an anchoring stent, then we can do flaring at the bottom end as required in order to abolish the left to right shunt. Because if you don't, here's an example of one where we thought there was enough security and we released the stent, but had a good result, but at 6 hours later, the stent migrated into the right ventricle. And just a point about the length of the stents, the shorter the stents, the higher the need for an additional anchoring stent. So you can see here, if you use a 6-centimeter stent, it's there's 74% incidence of requiring additional stent. A 7-centimeter stent, there was 30% of the cases needed an additional stent, and an 8-centimeter long stent, only a couple of the patients required the additional stent. Right upper pulmonary vein protection, we've mentioned. This is a 3D model simulation. And here's one case with showing the same concern about the right upper pulmonary vein compression. So an atlas balloon is inflated first, and then we implant with the balloon fully inflated at high pressure, we can then implant the covered CP stent, a long one, and you can see, excuse me, you can see a little bit of indentation on this lateral projection in the covered CP stent, and there's the final angiogram showing a very good result. As I mentioned, just to summarize, transseptal puncture and monitoring of the right upper pulmonary vein has really helped and made the procedure much more reliable. Non-compliant balloons replace the compliant balloons because that avoids bulging. Anchoring stent in SVC is very important, and the longer length of the stent is also important. I'll stop there. Thank you very much.
Thank you.